A specialized software analyzes the image to detect and quantify calcium deposits. And the scoring, the amount of calcium is scored using the Agatston method, resulting in a numerical value that reflects the severity of calcification. So, CCS protocol, calcium coronary artery calcification is detected using a standard protocol involving prospective ECG triggered axial scanning with a slice thickness of 3 millimeters. Standard tube voltage is 120 kV with tube current set as 120 to 150 MAS, which should result in acceptably low levels of radiation exposure from 1 to 2 MSV. So indication for calcium score CT, risk assessment for asymptomatic individuals at the intermediate risk of CAD to better stratify their cardiovascular risk. Family history. Individuals with a family history of heart disease may benefit from the test. Screening in individuals with risk factors such as hypertension, diabetes, high cholesterol, or smoking. Uncertain cases, when there's uncertainty about the need for preventive interventions based on traditional risk factors. And symptomatic individuals, occasionally used in patients with atypical chest pain or equivocal stress test results. So why is calcium score CT is important? First, assessment of coronary artery disease risk. It consists of risk stratification. Calcium score CT helps in stratifying the risk of CAD, especially in asymptomatic individuals. It provides a more precise assessment of an individual's likelihood of having significant coronary artery disease compared to traditional risk factors alone. Also, personalized risk assessment. The score aids in tailoring preventive strategies based on an individual's specific risk level. The second, early detection of atherosclerosis. It is non-invasive detection. The scan detects calcified plaque in the coronary arteries before symptoms arise, allowing for early intervention. Subclinical atherosclerosis, it can identify the presence of atherosclerosis even in individuals who do not exhibit any symptoms, facilitating early lifestyle and medical interventions to prevent disease progression. C, predictive value for future cardiac events. It has a prognostic indicator. A higher calcium score correlates with an increased risk of future cardiac events such as heart attacks and strokes. This predictive value helps clinicians and patients make informed decisions about preventive measures. Guidance for preventive therapies. The result can influence the initiation of intensification of preventive therapies like statins, antihypertensive medication, and lifestyle changes, thereby reducing the risk of future cardiac events. Also, comparison to other cardiac imaging modalities has specificity for calcified plaque, while other imaging modalities such as stress tests and coronary angiography assess different aspects of heart health. Calcium score CT specifically quantifies calcified plaque, providing unique information. Complementary tool, it serves as a complementary tool to other imaging modalities, offering additional insights into the extent of coronary artery disease and guiding comprehensive management strategies. The calcium score CT is a valuable tool for assessing coronary artery disease risk by quantifying calcified plaque in the coronary arteries. It is quick, non-invasive, and useful in guiding preventive measures for cardiovascular health. So what do we need to prepare the patient? So it is non-contrast CT acquisition, so it do not require much patient preparation compared to most other CT indications. ECG leads need to be placed on the patient's chest. The arms are extended above the head to avoid high radiation doses required to penetrate the extremities and to decrease beam hardening artifacts. Coronary artery calcium scoring methodologies. Ideally, non-contrast CT examinations would be ECG gated to minimize motion artifacts and provide the most accurate reproducible CEC scoring when reconstructed to the appropriate slide thickness, facilitating the use of the very large ECG gated CEC database. While this may provide better quality NCCT for non-cardiac structures as well, it may be difficult to implement on a broad scale since it involves additional hardware and ECG electrode scanner software and may increase radiation exposure. So here you can see the acquisition protocol. Position is supine, scanning mode is axial with prospective electrocardiographic gating, scan range from below aortic arch to base of heart, tube voltage and tube current time is fixed, as I said before, 120 kVp, section thickness 2.5 millimeters with interval of 1 millimeter, reconstruction and post-processing with axial soft tissue and lung windows, 2.5 millimeter section thickness, calcium scoring performed by using Aosor method, and approximately study time is equal to 10 to 50 minutes. So when we are talking about the calcium scoring, we need to know about the Aosor score. The method is based on the maximum X-ray attenuation coefficient or CT number measured in Hounsfield units and the area of calcium deposits. First, calcified lesions are identified on CT images by applying a threshold of 130 Hounsfield unit to the entire image set. Tissues with density equal to or greater than the threshold are considered to correspond to calcium. Each detected calcium deposit is evaluated based on its area and peak density. The Aosor score is calculated by multiplying the area of calcium deposit by a density factor, which is determined by a peak density of the calcification. So the density factor is categorized as follows. So 130 to 199 is density factor of 1. 200 to 299 is the factor of 2. 300 to 399 is density factor of 3, and above 400 is density factor of 4. For example, if a calcium deposit has an area of 5 millimeters square and a peak density of 250 Hounsfield unit, the score for that deposit would be 10, as the formula below. So, interpretation of Aosor score. If the score is equal to 0, then risk is non-identified. It has negative test. Findings are consistent with a low risk of having a cardiovascular event in the next 5 years. From 1 to 10, it has minimal risk. So minimal atherosclerosis is present. Findings are consistent with a low risk of having a cardiovascular event in the next 5 years. From 11 to 100, it's mild coronary atherosclerosis is present. There is likely mild or minimal coronary stenosis. A mild risk of having CAD exists. From 101 to 400, moderate calcium is detected in the coronary arteries and confirms the presence of atherosclerosis plaque. A moderate risk of having a cardiovascular event exists. So if it is higher than 400, a high calcium score may be consistent with significant risk of having a cardiovascular event within the next 5 years. So here we can visually see the type of calcification. So if this Aosor score is equal to 0, it's normal, and as the first photo. So in the second, it has moderate calcification, and in the third photo, so we have image. I mean, we have Aosor score more than 400. So on this slide, we can see the program interface for calculating the calcium score using the Aosor scale, which is used in our center. So it has two windows, axial and coronary. Coronal, I mean, which can help us to evaluate the calcium score. So first of all, we need to select the window, Excel, in which it will be most convenient for us to calculate the calcium score. The next step is to select the artery in which we found calcium. For example, in this image, we visually identify calcium in the left anterior descending artery. Accordingly, we selected the artery and manually clicked on the area of calcification. The program automatically calculated calcium score according to the Aosor score scale. So the score was equal to 0.9, which means the low risk of the minimal risk of the developing of coronary events. Here we can see case number 1, 46 years old man. He went to the clinic at his place of residence, which complains of discomfort, chest pain, tightness, burning after physical activity lasting more than 3 or 5 minutes. The cardiologist sent him to the heart center to determine the coronary calcium score. After conducting coronary calcium CT scoring, an index of 512 was calculated, which corresponds to a high risk of developing coronary events. Here we can see case number 2, 5-year-old man come to the calcium scoring, coronary artery calcium scoring according to the ongoing project at our heart center on coronary atherosclerosis. Didn't make any complaints and considered as completely healthy. After conducting coronary calcium CT scoring, an index of 364.3 was calculated, which covered the LM and LAD arteries, which corresponds to a moderate risk of developing coronary events. So calcium score calcification and artifacts. Potential pitfalls that can confound calcium score calcifications include coronary artery motion artifacts, non-coronary calcification, strict artifacts from adjacent metallic prostheses, and inclusion of patients who have undergone coronary artery stent placement or coronary artery bypass graft placement. So the advantages of coronary calcium scoring is it is rapid, does not require contrast, low radiation dose, reproducible, powerful prognostic data. Disadvantages are cost and radiation exposure. So in conclusion, I want to say coronary artery calcium scoring is a well-validated risk assessment tool that represents a major advance in screening for coronary artery disease. The evidence is sound and physicians must be made aware on the ways to incorporate this screening tool into clinical practice. Although it doesn't allow for the assessment of soft non-calcified plaque, it has shown a good correlation with contrast enhanced CT coronary angiography. Thank you for the time. Thank you for attention. Dr. Kashif.
Thank you, Dr. Almas. It's a great honor to have you here, despite a busy schedule on your end, which includes your son being sick, and still you made it. We are very thankful for your precious time, and thanks a lot. If there are any questions from the audience, we would like to hear them. If there are no questions, we will then move further with the next session. We can wait for 30 seconds. Professor Chow.
Yeah. Yes. May I have a question? Can you hear me?
Yes, we can hear you, Chow, sir.
Yeah, I got the question for Bima Khan because the cost is relatively high, as you mentioned. How about the price for each examination at your Kazakhstan?
Dr. Cho, thank you very much for your question. It approximately in tenge it costs to 20,000, and in dollars it will be approximately $45 per each scan.
45 US dollar.
Yeah.
Yeah, okay. Personally, I think it's still reasonable. Yes. And how about the current CT current angiography?
More than 100 USD, approximately $110 US dollars.
110. Yeah, I think it would be good if you can collect more data from the youth club alumni, that so that we can have a overall picture about the cost of this kind of examinations in different countries. Then we can we can have more information so that in the coming years we can adjust ourselves with which price will be most suitable for different countries, and probably also for the protocol. Probably you can also do a survey, if you like, do a survey for the Asian countries, so that we can modify our protocol sometimes if it's too costly, spend too much money. Then we can do something to save time or to save the the cost. It will be interesting.
Thank you very much. I want to add that nowadays we are preparing a project that can identify five diseases, including coronary atherosclerosis, by using low dose CT. I think in the near future we will share the results. Thank you.
Okay, thank you.
Okay, thank you so much for the input, Professor Chow and Dr. Almas, for your precious time. Thanks a lot. Moving ahead, we have next Dr. Nguyen Trang, Radiology Center, Bac Mai Hospital, Hanoi, Vietnam. So it's a pleasure to introduce Dr. Trang, because we actually met in the youth club, and he is a very shy and very introvert kind of person. That is what I felt, and but then I was hesitant, but still I asked if he could give us some time, because he's quite occupied. Actually, the bibliography mentions here just two, but he has already published more than 18 articles, and uh, he has completed his residency from Clermont-Ferrand University Hospital, France, and also an observer at University of Sydney and Westmead Hospital, Australia, and then the PhD, which was from the Taipei Medical University. And Sir is also a fellow of radiology at Rouen Hospital, France. So quite a few accolades there. And he's one of the leading researchers with respect to coronary angiography and cardiac imaging. And I hand over the podium to you, sir.
Thank you so much for your kind introduction, Kashif. Very highly appreciate for your organize this great event, which we have a chance to share some information, some knowledge about the radiology community. So let me share my screen. So can you see my screen clearly? Okay, can you hear me?
Yes, we can hear you.
Okay. So thank you for your kind introduction, and thank you for the organizing, especially AOSR and AOSOR, for giving us a chance to come back to this event. So following the very interesting topic about the coronary classifications and score, so I would like to share the information about the coronary CTA. So this is my outline. So as we know, this man, he is very famous scientist and artist, Leonardo da Vinci. So he also have a very early study about the cardiovascular image, cardiovascular system. And here we can find out some figure he already write out about the heart and the vessels. So nowadays we find out that the burden of cardiovascular disease is a global problem, especially in Asian Pacific area. And here we can see the red area here from the East Asia to the Southeast Asia and the other area in the Asia also. For the coronary artery disease, so we have two kinds of the disease. Some we can call stable or unstable chest pain. So with stable chest pain, this can occur with increased demand of the heart. With the stable plaque, for progressive or unstable angina or chest pain can associate very highly risk to heart attack. So if the patient has chest pain, we can have some kind of pathway. First of all, we check the clinical test, the clinical history, some simple tests like ECG or chest X-ray, but we need a test that can provide very important information about the coronary anatomy and characterize the coronary arteries. So here we can see for the cardiac test, we have many cardiac tests like from the ECG, echocardiography, CTA, and MRI or angiography. And here we can see that with the previous presentation, we can use the cardiac CT for the low risk or intermediate risk. And together with the coronary classifications, we can evaluate the coronary anatomy, the plaque imaging, and besides, we can have further information about the valvular imaging, myocardial perfusion, or FFR, the fraction flow reserve, and pre-procedural planning right now. For example, we can implant the aortic valve percutaneous. So for the guidelines, we can see that the many guidelines from the AHA, ACC in the 2021, all the guidelines from ESC, European Society of Cardiology, in the 2019, we can find out that right now CTA or coronary CTA is recommended at the class 1A together with the echocardiography, and this is like a non-invasive functional imaging to find out for to check for the coronary CTA, and this is very highly recommended for the patient with the chest pain or with the CAD suspected at low and intermediate level. So back to the coronary artery, we already have the presentations, and I just briefed that the coronary artery classification or CAC, now the gatekeeper as an independent risk stratifications and very high NPV. But after 30 years until now, the CAC score, it becomes zero, still very good predict factor with very low incidence of major cardiac events in patients with stable chest pain or acute chest pain below to the recent study. So follow up to the history of the CT, we know that since the beginning of the CT with the first CT scanner, sorry, this is in Vietnamese, but we are from Mr. Hawkins. Until now, we have many other kind of the CT technology has been instant and launching like spectral CT, photon counting, or ultra high resolution CT, and that's very helpful for the improve the time resolutions for the cardiac coronary CT and the spatial resolution for this. And you know that with the 4th line or 16 line or 64th line and even later after 64th line, we can improve the image quality like that. So we can see more clearly the coronary artery together with the plaque also. And after that, we can have we need the ECG gated. And we concern about the time resolution. For example, in our department right now, we use the dual source from Siemens, and the temporal resolution is as good. So we do not need the beta blocker, and we can scan the image is a reasonable image quality. And with some kind of protocol, we can scan the patient in cardiac in coronary CTA with the mode flash, that is 1 heartbeat, or we can use a prospective gated or the retrospective gated. That depends on the indications. So the heart rate is very important for the other effect image quality. If the heart rate is low, or like 60 ppm, then we will see the image quality is quite nice. We can scan the patient with a long diastolic phase enough. But if the heart rate is very high, like 100 ppm like that, so we can have the blurring image. So we can use a prospective or retrospective scan of the patients that depend on the heart rate, and the reconstruction the image in the end-diastolic or systolic phase. And together with the beta blocker, we know that if we reduce the heart rate, we can have the good image quality that follow another for study in the worldwide. Nitroglycerin is also one of the important factors. If we use this, 1 or 2 dose sublingular, we can improve the image quality with very high sensitivity or specificity in comparison with the nitroglycerin. Some other factor we should consider when we do the coronary CTA, like the density. We need the very good density in the very small lumen, very small vessel like this. So we can use the injector phase, like if we inject too much like monophasic here, we can have the artifacts that can cause the high density of the contrast material. And if we use a dual phase biphasic, we use a saline to push, so we do not have the artifact from the right heart. But in sometimes we need to see also together with the left heart and the right heart, so we can use a dual flow or together with this. And the radiation dose is very important. Things when we scan the patient with coronary CTA, with the new machine right now, we can have a very low radiation dose and less than 1 millisievert. And even very big patient like this, 100 kilograms, we still have the good image quality. And some of the paper already mentioned about this. We can reach the radiation dose very low if the still suitable situations. For the then we analyze the coronary anatomy. We can know that it is the two main arteries from the right and the left. So we have here the right coronary artery, and then left main, and then we have the LAD, left anterior descending artery, and the circumflex artery. This is the 3 main coronary arteries. Sometimes we and then we analyze all the segments of the 3 mains, like we use 16 segments from AHE, has been recommended a long time ago. So we had 3 from the right, 3 from the 1 left main, and 3 from LAD, and 3 from L6, and 1 is PDA, and the other one is the diagonal or obtuse marginal also. So that's it. And also normally from our experience, we use a VRT image to check, or ICN image to check if the coronary artery is normal anatomy or not. That means the original, for example, the right coronary artery originates from the right sinus vasa, and the left one is together with the left. But sometimes we have the other like high takeoff or multiple osteo, or the abnormality originate of the left or the right artery. For example, this patient, we have the 58 years old female patient, and then we can see that the RCA is originated from the left side. And that's the very high risk because this compressed by the ton of the pulmonary artery PA and the aortic valve here. And the another patient that you can find out that the left main it come from to the right right sinus here. And another thing is that we can have the originate abnormal, the originate of the left coronary artery come from the pulmonary arteries. and that can cause the ischemic due to the result of the correction of the artery flow. Another case, we have the female patient, 57 years old with chest pain, and here we can have the left the L6 is come from the right coronary sinus and compressed by the aortic and go together with the left LA. Another case, we have the men 55 years old with unstable chest pain, and we find out when we scan the patient, we can find out here that this patient have the bilateral coronary fistula to the pulmonary artery, and this is the main cause of the patient has chest pain with no significant stenosis. Sometimes we can find out that the patient have the myocardial breachings. That means the pathway of the coronary that's compressed by the myocardium here, and this can, especially in the end-systolic phase, that can cause the chest pain, or sometimes can cause the ischemic for the patient, like this patient, LAD here, in the end diastolic, and in end systolic here, we can see that the muscle compressed, the myocardial muscle compressed very strongly, the LAD, and similar with this is we can have this milking effect. That's the image when we do the ICA percutaneous coronary angiography, systolic phase and systolic phase here and the diastolic phase here. So when we analyze the coronary CTA, so first as we discussed, we take the step one, review the image quality. That's many factors that we can take care about the heart rate, about the image quality, artifact or not. Then we evaluate the coronary segments and plug analysis. And then now we have the CART-RAS category from 0 to 5, and then N is not available. And step 2, 4, we assign the CART-RAS. Maybe we can use the CART-RAS 2.0, that is now with modified non-diagnostic stent or biograph or vulnerable part. And then we can structure the reporting. That is the 5 steps we use when we analyze. So this is the first one. We analyze just use the image, ICA image, and we check the anatomy together with the coronary anatomy. We check the other related anatomy like the aortic, ascending aortic, or LV, LA, or RA, etc. And sometimes we check for the dominant coronary. If the patient have the right, normally the patient have right dominant PDA, that's a PDA come from the RCA. Sometimes they have two coronary PDA that can cause the balance, and then some patients have the left dominant arteries, that's the PDA come from the L6. And here you can see some example of patient. This is a main patient, 36-year-old with very high heart rate here. Even the heart rate is very high, we still have the reasonable image qualities. And this patient, we find out that there is no stenosis, and calcification score is 0, and with the dose is very simple. Recently, we have a consensus statement from coronary stenosis followed by the SCCT. This is come from ASCI, Asian Society of Cardiovascular Imaging, give a statement on the blood evaluation on in CT angiography. For example, in this patient, sometimes we do not make sure that this one is this is left main, this is L6, and this one is LAD. But at this point here, arrow here, sometimes some doctors can say that it is this is the proximal, or sometimes this is the mid LAD. So with this consensus, we agree that this is the right after the originate of the D1 here. So this is the LAD2. And how we evaluate the coronary artery stenosis? We use the NASS. Here we can evaluate the percentage of stenosis by diameter. Somehow we can evaluate by the area also. But in the clinical practice from us, we use the diameter to follow together, have a good correlate with the ICA. And then we can have the CART-RAS. It is the CART-RAS 1.0 0. So we can evaluate from 0, 1 to 24, mild, moderate, and then higher and occlusion, severe also here. So for example, this is a female patient, 72-year-old with chest pain, and this patient has very irregular heart rate from 36 to 101 BPM. Well, you can see the image quality is quite nice. We can have the VRT image, and then we can see on the image the segment of the coronary artery. And here we can very mild stenosis of LA1 and 2 here. So about the cataract, we can say this is the cataract. This is the cataract 2 or 1. This is my very mild moderate stenosis. And this is one. The other patient is the 62 years old with chest pain, and the heart rate is reasonable, only 60. The CAC consume score is only 0, but you can see a soft plaque here about at the mid LAD. So this is the 60 about 60% of stenosis. So this is cataract 3. The other one is there is no other vulnerable plaque. And when then we analyze the vulnerable plaque, for example, some characteristic like positive remodeling and napkin ring size, spotty consume, and then we can have some very high risk of the ruptures in the future. Recently, we have the cataract 0.2.0 with can use together with the FFR and CTP, but the classification is similar with the cataract 1. So another patient here, we can see that's a very good image quality here. On the image, the coronary from RCA, LAD, coronary circumflex, this is the cataract 0. There is no plaque, and there is no need to management, just follow up the patient. And the other one, we have a very small calcification of the LAD here. So this is the cataract 1 from stenosis from 1 to less than 25%. The other one patient here is we can have the LAD with the calcification and some sort of plaque here. So this is the we arrange that cataract 2 from less than 50%. Another case here we have the cataract 3 at the LAD also, area of very significant stenosis here. And we have together with this, we in the SCCT guideline from the 2011 and 2014, we checked which the plaque is the non-calcified or partial or predominantly, and from the calcified to non-calcified to calcified plaque also. And we check for the coronary plaque burden in the cataract 2.0 here from the P1 to P4. With the calcium score here, we can check it mild, moderate, and severe. Extensive is more than 10,000. And especially now, right now, we have more elderly patients with the severe of the calcification score is from 300 and to more than 1,000 plaques. Another example here is we can have a cataract 4. You can see here with this very significant stenosis, and follow this of the LAD and follow with the ICA. And another case is 4B with the triple cell here, and this is the cataract 4B, RCA, LAD, and LCA also. And cataract 5, because here we can see there is no image, there is no contrast material at the second part of the RCA, total occlusion of this area. But when we analyze after we analyze the coronary CTA, we analyze the anatomy, we analyze the stenosis or not, and the location and the situation of the plaque. We should take care of the other things, for example, the cardiac chamber, the myocardium, the valve, or the lung. For example, in this patient, when we scan the coronary CTA, we can find out that there is small PFO here, or the patient also have the lesion of the nodule or lesion of the left lung, or we can check the cardiac chamber, like 4 chamber, 2 chamber, etc. And in this area, we can find out the myocardium here is thinner than in comparison with the other one, and with hypodensity, the endocardial, like the area of the LAD. And some patients have the myocardium infarction and can cause the degeneration of fatty degenerations or calcification like this. This is like the sequence due to the infarction. And aortic, and the other like the vein, especially the aortic vein right now here, you can have the calcification and the degenerative, and the lesion of the aortic vein like this, or we can divide by the Windman or not, 1 to 4. And we sometimes we can find the vegetation of the aortic vein, or that can cause lesion at the pulmonary lung bilateral like this, like due to the septic emboli. And sometimes we can find out that maybe the patient have the mass here. This is very big mass at the LA. And then it can go to the mitral vein to go down to the LV. This is like a movement mass. So we, with the normal coronary arteries, and then we can think that the mild enhancement when things such as this can go like a myxoma with the border is reasonable. So as we know, that's the developing of the coronary CTA, especially the technology right now. We can have a lot of application, especially the AI. So we can, with the coronary CTA right now, we not only check for the coronary artery disease, the plaque, the calcification, but now we can have more information about the function like the CTFR or CT perfusion. We check for the scar. And together with the other thing, we can see there's the outer chamber, the outside the cardiac. So with that, I believe that it is coronary CTA right now become the very good and one-stop technology to rule out and check for the CAD disease. Thank you for your kind attention.
Thank you, Dr. Nguyen. If there are any doubts or if anything Dr. Nori or Dr. Chow would like to add, we will wait for 30 seconds. So there was a question, what is the upper limit of calcium score to avoid CT angio? Dr. Almas, would you like to contribute anything extra for that?
Thank you for the question. And the answer is the decision to avoid CT angiography based on the calcium score isn't strictly governed by a single upper limit, but rather depends on the clinical context and the specific patient's risk factors.
We'll move ahead then. Moving to the next in focus sessions. These were the primer sessions. So I hope the second year residents would have enjoyed this. The basics of cardiac CT and coronary angio. So now we are going in towards higher level topics such as imaging in prostate malignancy and biopsy. So the third speaker for today's session, Sumit, can we please have, yeah. So Dr. Tokuda, actually, Dr. Tokuda, I had a very funny conversation because he is also very shy. I think all the esteemed speakers who have a lot more knowledge are more shy than me. Nonetheless, they have a great helm in their subject. And Dr. Tokuda hails from Kyoto Prefectural University of Medicine. Graduated PhD in radiology in 2022 and has got a top prize at image interpretation session at annual meeting of Japan Society, and is one of the leading young radiologist who is doing a lot more research in prostate imaging and intervention. I request Dr. Tokuda to please take over.
Thank you for your introduction. I prepared a lecture video, so let me start now. Just
Sir,
wait.
please tick on the share sound button.
Sorry.
Sir, please tick on the share sound button before sharing your screen, sir.
I see.
It's right in the left side of the bottom.
Okay.
Hello everyone, I'm Dr. Bunta Tokuda from the Department of Radiology at Kyoto Prefecture University of Medicine, Japan. I'm honored to speak at this webinar. Today, I'd like to talk about MRI diagnosis of prostate cancer with pilots. Prostate cancer is the most frequently diagnosed cancer among men in more than half of the countries. It is also the leading cause of cancer-related deaths among men in several regions. The mortality to incidence ratio in Asia is significantly higher than in North America. Early diagnosis and treatment play an essential role in reducing the mortality rate of prostate cancer. Let's review some key terms related to prostate cancer. PSA is a glycoprotein produced by prostate tissue, useful for screening and assessing treatment response for prostate cancer. PSA density is the ratio of serum PSA to prostate volume. Higher values of PSA density suggest clinically significant cancer. The Gleason score is a histological grading system used to evaluate cancer aggressiveness ranging from low risk to high risk. Clinically significant prostate cancer is defined as Gleason score of 7 or higher, a tumor volume of 0.5 cubic centimeters or more, or extra prostatic extension. Prostate cancer is common in the elderly. Therefore, to avoid overtreatment, cancers that do not affect patient prognosis are generally not treated and just followed up. MRI is a powerful tool in the detection and localization of clinically significant prostate cancer. Using the Prostate Imaging Reporting and Data System, PILOTS version 2.1 for MRI interpretation increases the detection rate of clinically significant prostate cancers, reduces the overdiagnosis of insignificant cancers, and decreases the number of unnecessary biopsies. MRI can also be used population-based screening for prostate cancer. Several guidelines recommend MRI before deciding whether to perform a prostate biopsy. As a topic beyond diagnosis, patients with PILOTS 4 or 5 lesions are more likely to develop recurrence after treatment and experience metastasis and cancer-specific death. Understanding normal prostate anatomy is crucial for accurate MRI interpretation. The prostate is divided into several zones: the central zone, the transition zone, the peripheral zone, and the anterior fibromuscular stroma. The peripheral zone is the most common site for prostate cancer, followed by the transition zone. Benign prostate hyperplasia (BPH) develop mainly in the transition zone and making the evaluation of cancer difficult. PILOTS provides a standardized framework for reporting prostate MRI findings. PILOTS aim to improve the detection, localization, characterization, and risk stratification in patients with suspected cancer. PILOTS version 2.1 uses a 5-point scale to indicate the likelihood of clinically significant prostate cancer based on MRI findings. Categorization is based on the evaluation of multiparametric MRI findings, including T2-weighted image, diffusion-weighted image, and dynamic contrast enhanced image. As shown in the flowchart on the right, the dominant sequence is defined according to the location of the lesion. For peripheral zone, DWI is the dominant sequence and DCE provides additional information. For transition zone, T2II is the dominant sequence and DWI provides additional information. The overall pilot category is determined mainly by the score of the dominant sequence. The overall category may be upgraded by the score of the additional sequence. In general, cancers in the peripheral zone are relatively easy to detect because they contrast with the surrounding normal prostate tissues. On the other hand, transition zone cancer may have a similar signal intensity to the surrounding tissue and are difficult to detect. Therefore, I'll start with explaining the evaluation of peripheral zone first. Clinically significant prostate cancer in the peripheral zone typically appears as markedly hyper-intense on high p-value diffusion-weighted image and markedly hypo-intense on LC map. Signal intensity should be visually compared to the normal prostate tissue in the same zone. DWI findings should always be correlated with T2 weighted image and dynamic contrast enhanced image. Here is an example of DWI scores. Score 1 means no abnormality. Linear or wedge-shaped lesions reflect inflammation or fibrosis and are assigned to score 2. Focal lesions with mild to moderate diffusion restriction are assigned to score 3. Markedly diffusion-restricted focal lesions are assigned to score 4 or 5 depending on their size. Definite extraprostate extension is also scored 5. On T2 weighted image, clinically significant cancer in the peripheral zone usually appears as round or ill-defined hypointense focal lesions. However, this appearance is not specific and it is crucial to correlate with DWI and DCE. Here is an example of T2 weighted imaging scores. As well as DWI, linear, wedge-shaped, or diffuse mild hypointensity is considered inflammation or fibrosis and assigned score 2. Focal hypointense lesions are assigned score 4 or 5 depending on their size. Prostate cancer often shows early enhancement compared to normal tissue, and dynamic contrast enhancement (DCE) provides additional information that can be crucial when other sequences are inconclusive. Focal enhancement suggests malignancy, while diffuse enhancement usually indicates inflammation. Here is an example of DCE. Positive DCE indicates focal earlier than or contemporaneous with enhancement of adjacent normal prostate tissues and correspond to a finding on T2 and or diffusion-weighted image. So, let's evaluate some cases based on pilots. Please try to score each sequence and the overall pilot category. DWI shows a focal lesion with marked diffusion restriction in the left peripheral zone, making this lesion DWI score of 4. T2WI shows a focal hypointense lesion in the same area, making this lesion T2 score of 4. The lesion shows early contrast enhancement. Based on the DWI finding, the overall pilot category is 4. Let's move on to the next case. Please score each sequence and the overall pilot category. DWI shows a focal lesion with marked diffusion restriction in the right peripheral zone. DWI score is 5 due to its size. T2WI shows a focal hypointense lesion in the same area, making this lesion T2 score of 5. The lesion shows early contrast enhancement. Based on the DWI finding, The overall pilot category is assessed as 5. Then, how about this case? DWI is distorted by artifact from rectal gas, so we can't score this sequence. T2WI shows a focal hypointense lesion in the left peripheral zone, and T2 score is 4. The lesion shows early contrast enhancement. Overall pilot category is not assigned because DWI cannot be scored, but the finding of T2WI and DCE suggests a clinically significant prostate cancer in this case. Here are 2 cases of prostatitis. Prostatitis is common and often subclinical and can mimic cancer on MRI by causing decreased signal on T2 weighted image and ADC map and increase the perfusion on DCE. However, prostatitis usually presents with band-like, wedge-shaped, or diffuse patterns rather than focal lesion, and hyperintensity on the ADC map is generally not as pronounced nor as focal as cancer. Now, let's move on to the evaluation of transition zone. TZ cancers appear as non-circumscribed homogeneous, moderately hypointense, lenticular-shaped lesion with absence of hypointense capsule and may invade other structures. As I mentioned earlier, detecting TZ cancer is challenging due to the heterogeneous signal of the normal TZ tissue. Here is an example of T2 weighted imaging score 1 and 2. Normal transition zone or typical nodule is assigned to score 1. Typical nodule is defined as a round, completely encapsulated nodule. A mostly encapsulated nodule, atypical nodule, or homogeneous mildly hypointensity between nodules are assigned to score 2. A typical nodule is defined as a homogeneous circumscribed nodule without encapsulation. T2WI score 3 is an equivocal finding, defined as a heterogeneous signal with obscured margin that does not correspond to any of the other scores. Lenticular or non-circumscribed homogeneous moderately hypointense lesions are assigned to 4 or 5, depending on their size, and definite EPE is also scored 5. Similar to the peripheral zone, clinically significant prostate cancer in the transition zone shows marked diffusion restriction. However, some BPH nodules may exhibit diffusion restriction, complicating the assessment. Here is an example of DWI scores. The evaluation criteria are the same as for peripheral zone lesions. The evaluation of DCE is also the same as for peripheral zone. However, in the transition zone, BPH nodules often show early enhancement. To differentiate them from cancer, evaluation of morphology and signal intensity on other sequences is required. Okay, let's evaluate some TZ cases based on pilots. Please try to score each sequence and the overall pilot category. DWI and ADC maps show a focal lesion with marked diffusion restriction in the right transition zone, making the lesion DWI score of 4. Although it's a little difficult to recognize, T2II shows a focal hypointense lesion in the same area, and the T2 score for this lesion is 4. The lesion shows early contrast enhancement. Based on the T2WI finding, the overall pilot category is 4. This is the next case. Please score each sequence and the overall pilot category. DWI and ADC maps show relatively large focal lesion with marked diffusion restriction in the left transition zone, making the lesion DWI score of 5. T2WI shows focal hypointense lesion in the same area, and the T2 score for this lesion is 5. The lesion shows early contrast enhancement. Based on the T2WI finding, the overall pilot category is 5. How about this case? We can see a round, completely encapsulated nodule with mild diffusion restriction and early contrast enhancement. Based on the T2 score 1, the overall pilot category is 1. This is typical BPH. BPH nodules often show restricted diffusion and focal contrast enhancement. Therefore, careful assessment of shape, capsulation, and signal intensity on T2WI are required. This is the last case of TZ lesions. T2WI shows homogeneous hypointense partially encapsulated nodule, which is considered a typical nodule. DWI and ADC map show marked restricted diffusion, and DCE shows early contrast enhancement. Based on the T2 score 2 and DWI score 4, the overall pilot category is upgraded 3. This atypical nodule with restricted diffusion may contain clinically significant cancer. Therefore, it should be reported as pilot 3 and consider biopsy. Regarding what TZ lesion to score, pilots state that lesion with more restricted diffusion than background should be scored. Thus, while the dominant sequence for TZ lesion is T2WI, you can pick up a lesion with TWI and then evaluate it with T2WI. And of course, if there is a typical hypointense lesion on T2WI, it should be scored even if diffusion restriction is not obvious. In my opinion, T2WI is important for large invasive lesions because diffusion restriction may be unclear in that case. But for localized lesions, T2WI alone is difficult to evaluate, and combining with DWI and DCE is important. Regarding how to score, you don't need to score typical BPH nodules. Also, mild or moderate diffusion restriction is common with stromal hyperplasia, so the category should not be upgraded unless marked diffusion restriction is present. As we have seen, TZ is difficult to evaluate, so I'd like to introduce a study that may be of some help. This figure shows the distribution of TZ cancers. TZ cancers predominantly occur in anterior third and inferior half of TZ, and less frequently in the posterior third. Therefore, if a solitary lesion is found in the posterior third of the TZ, it is more likely to be BPH rather than cancer. I cannot say that this is always the case, but it can be helpful in making a decision in equivocal cases. Next, I'd like to talk about the measurement. To calculate the PSA density, you need to measure the volume of the prostate gland. As shown in the figure, just measure 3 dimensions and calculate the prostate volume. It is recommended that PZ lesions should be measured with ADC map and TZ lesions with T2WI. However, if measurement with these sequences is difficult, the sequence that shows the lesion best should be used. Then, let's review T-staging. T3 and T4 must be diagnosed properly with MRI. Imaging features for T3A are shown here. Tumor capsule interface of greater than 1 cm, bulging prostate contour, irregular or spiculate margin, asymmetry or invasion of neurovascular bundles, obliteration of rectoprostatic angle, and breach of the capsule with direct tumor extension. Here is an example of T3A case. Infiltrative lesion is mainly in the left PZ, with obscuration of the prostate contour and irregular protrusion beyond the capsule, suggesting extraprostatic extension. This is a typical case of seminal vesicle invasion, T3V. You can see a large lesion in the left lobe in the mid-gland, and T2 hypointensity with diffusion restriction and early enhancement in the left seminal vesicle. Careful observation is required because these findings may be slight. This is the scheme of the rectal and bladder invasion. In both cases, it is important to confirm the disruption of T2 hypointensity that suggests the muscular layer. These are typical cases of rectal or bladder wall invasion, T4. You can see the disruption of T2 hypointensity of rectum or bladder wall. Let me conclude with some tips. The central zone is a normal structure that can easily be mistaken for cancer, so be sure to understand it properly. It is confusing because the central zone shows T2 hypointensity and mild diffusion restriction, but it is distinguishable from cancer by its shape, location, and lack of early enhancement. Some cancers can arise from CZ, but they are rare. The left images show the normal central zone. It is bilaterally symmetrical at the base of the prostate and Y-shaped in the coronal image. Mild diffusion restriction is seen, but no early enhancement. The right images show cancer arising from the central zone. Symmetry is lost and early enhancement is observed. Note that even a normal central zone may show asymmetry in size depending on the slice section or BPH. It is important to check whether early enhancement is present or not. Combination of PSA density and pilots has been reported to improve diagnostic performance. It is especially useful for pilot 3 lesions, which are unequivocal and difficult to manage. If the pilot 3 lesion has a PSA density of less than 0.1, biopsy is not necessary. And even for pilot 1 or 2 lesions, biopsy is recommended if the PSA density is greater than 0.2. At the end of my presentation, I'd like to talk about biparametric MRI. Since the role of DCE is limited in the current pilots, biparametric MRI that omits DCE may be performed. Although some reports indicated that there is no difference in diagnostic performance between biparametric and multiparametric MRIs, it has been noted that the number of pilot 3 lesions may increase and diagnostic performance may decrease in certain situations in biparametric MRI. For example, DCE is required when DWI is inconclusive due to artifacts. Also, it has been reported that the use of DCE improves diagnostic performance in non-experienced readers. In conclusion, this presentation describes the imaging evaluation of prostate cancer using pilots. The purpose of pilots evaluation is to detect clinically significant cancers. Non-clinically significant cancers do not need to be detected. The primary goal should be to master the evaluation of PZ lesions, since their detection is relatively easy. Evaluation of PZ lesions remains challenging, even for experts. Therefore, it is sufficient to detect obvious clinically significant cancers. I hope my presentation will aid in your clinical practice and contribute to improve patient outcome. Thank you.
Thank you, Dr. Tokuda. That was an in-depth analysis of PIRATs, and there were very nice cases that were shown. A few of them actually very helpful for residents. I am hoping that this is a treat for residents to actually rewatch later, which will be available up to 2 weeks. If there are no doubts, we can proceed with the next session. Dr. Chow and Dr. Nori, would you like to add anything? We will wait for 30 seconds.
Actually, I enjoy all three speakers' speech and, very informative. Thank you very much. I enjoy it. Thank you.
Thank you, Dr. Chow. So there are no doubts from the audience as of now. They can contact Dr. Bunta anyways later. The email ID was mentioned. Moving up, now we have Dr. Nicole Kesavi. Actually, she has done a lot of work in genitourinary imaging and is also a recipient of the prestigious Health Manpower Development Plan Fellowship Award for Advanced Imaging of Urogenital Oncology and Pelvic Diseases for Sustainable Tertiary Care. Administrative positions, Dr. Nicole has held several positions, including the Chief Resident Transitional Year Residency Program at the National Healthcare Group. Apart from that, also for the Radiology Residency Program, and presently she is an adjunct lecturer at Lee Kong Chian School of Medicine. She has 8 publications in national and international journals. I hand over the podium to Dr. Nicole.
Okay, thank you very much, Kashi, for that kind introduction. So I'd like to start my talk today on the MR-guided biopsy techniques in diagnosing prostate cancer. So it's somewhat of a sequel to what Bunta just spoke about. I have no conflicts of interest to disclose. This is actually the hospital I work at in Singapore. It's the most centrally located integrated health hub. On the right, we have the tertiary acute care hospital where our radiology department is based. And we also serve the adjacent step-down care facilities and community hospitals on the left. So as Bunta mentioned, prostate cancer is a very common type of cancer. It's the 4th commonest cancer worldwide. In Singapore this year, it has been listed as the first cancer that is commonest. And screening is actually indicated in asymptomatic men more than 50 years old or in men more than 40 years old with risk factors such as that of a positive family history. Screening is usually performed via the digital rectal examination, during which the clinician may find areas of nodularities or induration, as well as with serum prostate-specific antigen levels. So at present, the systematic transrectal ultrasound guided biopsy is the current standard for diagnosis, pathologic grading, risk stratification, and prognostication of prostate cancer. But systematic biopsies also have their limitations, and it can actually miss up to 30% of clinically significant prostate cancers. And the sensitivity is further reduced in large volume glands. So tumors may also lie in difficult to access areas, areas such as that of the anterior transition zone, the anterolateral peripheral zone, and the apex, which can also result in undersampling. So as such, there is currently a growing interest in MR-targeted sampling, which I'll be sharing more about. 3 main techniques. The primary use of multiparametric MRI of the prostate is for lesion detection with the intention of tissue sampling. So 3 main techniques would be that of the direct in-bore MRI guided biopsy, the cognitive method, or lastly, the third method would be that of the fusion technique, which I'll be focusing most on today because it is sort of the gold standard method right now. The first in-bore guided technique allows for confirmation of the biopsy site, but this can be expensive, time-consuming, and limited in availability because it actually occupies the MR scanner for quite a substantial time. The second method is the cognitive or visual-directed MR targeted biopsy. So this second method has actually shown the most inter-operator variability due to the reliance on spatial orientation of the lesion from the MR, which is used to direct the ultrasound and the biopsy needle by the operator. Using this technique, the radiologist actually reviews the acquired MR images and determines the location of the target lesion relative to normal anatomical landmarks. So you can use structures such as that of the urethra, the prostatic base, the seminal vesicles, or you can use like other fiducials, such as that of cysts or calcifications. And while performing the transrectal ultrasound, the operator cognitively determines the target lesion site using these landmarks and performs tissue sampling. So you can see that this method is not the best. There can be difficulty with small lesions or targets away from that of the ultrasound transducer. For example, anteriorly located tumors in very large glands. It's relatively inexpensive when compared to the fusion technique, however. Yeah, so the third method is actually that of the transrectal ultrasound combined with the MRI technique. This third method is actually the one that allows for lesions to be targeted with ease and efficiency while remaining readily available. So between the cognitive and the fusion methods, they actually have some common features amongst them. So firstly, the multiparametric MR must be the prostate gland itself and the targets on the same pulse sequence, which is usually the T2 weighted axial sequence. Accurate segmentation of the prostate gland is important because it is this segmentation that will be fused to the segmentation at the time of the transrectal ultrasound to provide targets. Processing should be available and exported to the image fusion targeting system before the biopsy session. An expert technologist can perform the segmentation based on the annotation of the multiparametric MR by the interpreting radiologist. So both types of biopsies combine the advantage of lesion visualization from the MR with ease and availability of ultrasound-based biopsy platforms for real-time imaging. So the literature out there is very vast. It is as to whether the cognitive technique is inferior when compared to the technique. Many trials, the one that I wanted to highlight is the Future trial performed in the Netherlands with 665 patients between 2014 and 2017 across 3 different hospitals. And all patients actually underwent 3T multiparametric MR and were scored according to PIRATS. So if the imaging demonstrated lesions with a PIRATS score of 3 and above, these patients were then randomized for one biopsy technique, be it the in-bore MRI method, the cognitive method, or the fusion biopsy technique. And this study actually found that there was no significant difference in the detection rates of clinically significant prostate cancer amongst all 3 techniques. But there also are other papers out there in which researchers have actually reported that the cognitive method is inferior when compared to the fusion technique due to the greater amount of interoperator variability. And as a result, it may actually miss a large number of clinically significant prostate cancers. So at present, right now, the consensus statement of the American Urological Association and the Society of Abdominal Radiology actually justifies the use of cognitive biopsies in resource-poor settings, but actually recommends the fusion technique wherever expertise and facility are available. So I will now share more specifically about the software-assisted fusion biopsy technique, what I learned on fellowship, as well as it is what we use back in my home hospital in Singapore. There are 3 key tracking methods which combine the advantage of lesion visualization from MR with ease and availability of the ultrasound-based biopsy platforms for real-time targeting and imaging. So first one, we have the image organ-based tracking, and the next 2 are sensor-based tracking methods. We have the electromagnetic method or the use of a mechanical arm. In the first image organ-based tracking method, this is different from that of the sensor-based registration because the computer actually tracks the organ itself and not the transrectal ultrasound probe. There is fusion of the prior MR with real-time 3D ultrasound using a surface-based registration and an elastic organ-based deformation algorithm. So the acquisition is actually done in 3 steps, starting with the rigid landmark-based registration, followed by multiple point-based rigid registration, and lastly by the elastic 3D-based organ registration. I have here two schematic diagrams actually, the one on the left showing the rigid registration and the one on the right showing the elastic registration. So you can see on the image on the left, where my cursor is pointing, that 3 points have been placed on the MRI image in image A1, and another 3 points have been placed on the truss image on image A2. And when you superimpose both images on one another, differences in the prostate shape and deformation actually do not allow for an accurate prostate overlay after rigid registration is applied. And similarly, in the second row, multiple points have been placed around the MRI and truss prostate contours. The third image that you see in B3 is a rigid registration, which still lacks accuracy owing to the differences in prostate shape. And then the last image in B4 is when an algorithm is then applied. So with the use of elastic deformation with surface-based registration, it actually allows for deformation of the MRI prostate shape to produce a more accurate registration. And on the schematic diagram on the right over here, it now demonstrates the efficiency of elastic registration. You can see the original shape of the prostate gland in the top row with the corresponding 3D shape in the second row. In the middle column, induction with a mathematical model actually shows posterior deformation of the prostate gland with this spherical indentation, which actually simulates the insertion of an ultrasound probe. And in the right-handmost column, after activation of the elastic registration software, the original 3D shape of the prostate gland has been rebuilt. So suspicious lesions are then loaded onto the system, which projects the target into the biopsy aiming mechanism on the ultrasound probe. The second method is that of the electromagnetic sensor-based tracking method, which uses a non-rigid registration algorithm for the advantages with this approach is that it allows for real-time spatial tracking of the targets and needle location. This technique also offers a more familiar approach in hardware design because the clinician will already know how to use the ultrasound probe in a freehand manner, which allows for multiple degrees of access during the procedure and can be rather intuitive to use since we use it quite often. But then having said that, it can also be a double-edged sword because it does require more familiarity with hardware design. It may also introduce human error as a result. Also, biopsy techniques that use a freehand method are more likely to cause prostate deformation because it is difficult to maintain consistent pressure without mechanical support. And registration may no longer be reliable when the registered contour does not line up with the prostate in live ultrasound. So to complicate things further, the operating physician must keep their hands on the probe at all times during the procedure, which can limit their mobility. And as a result, sometimes an additional assistant is required. So when you need an additional assistant, of course, it involves more dedication of additional time and money on part of the clinical practice. The field generator may also be susceptible to interference from other metallic objects in a workspace, which can distort the machine signal, possibly resulting in inaccurate tracking of the entire procedure. So during the biopsy, the field generator may need to be moved and recalibrated for each patient, and this will therefore add to the length of time taken for the procedure. The third method is similar to the second method, which I just mentioned, but it is different in the aspect that it uses a tracking arm, which is attached to the conventional ultrasound probe. So over here on the image on the right, you can see that there is a ultrasound probe that is held by the mechanical arm. As a result, this method is less operator dependent, but also relatively more expensive. The mechanical arm is good because it applies consistent pressure on the prostate gland, allowing for maximum accuracy of registration and consistent coupling. However, also given the use of the mechanical arm, it is beneficial in the sense that it enables the physician to take hands-free pauses and reduces the need for a second assistant. So the image here shows the transperineal approach. Mechanical arm is used, and the ultrasound probe is inserted. Where you see at the posterior aspect of the patient in a lithotomy position. So many vendors out there on the market, different approaches available. This is just a summary table that demonstrates it, be it the transperineal route or the transrectal route, and the different types of tracking systems available. So many systems out there, but the key steps remain the same in the entire process of the fusion method. These steps may occasionally be interchangeable dependent on the institution and their methods of clinical practice. For example, whether the radiologist or the urologist is actually the one who conducts the biopsy. By and large, however, all systems actually start off with the acquisition of the MR images, analysis and review, followed by administration of the periprostatic nerve block by the procedurist. Then the procedurist will go on to acquire the transrectal ultrasound images, and then segment and fuse both MR and transrectal ultrasound images, and lastly, making use of probe tracking to perform the actual biopsy. So step one of the process, the acquired MR images are uploaded onto the segmentation software for mapping of the suspicious lesion. The radiologist segments the prostate gland and the target lesion separately on the T2 weighted images. The adequacy of the segmented volume can also be verified on the sagittal and coronal images, and the segmented volumes are then fed into the fusion biopsy system. So here, I have the setup of how it looks like in the procedure room. The image on the left shows the necessary equipment needed to conduct the biopsy, predominantly the local anesthesia as well as a spring-loaded biopsy gun. And the image on the right actually shows the ultrasound workstation and articulated robotic arm. So the mechanism can actually differ from vendor to vendor. But for this particular image, the articulated robotic arm contains the magnetic field generator. In the second step, periprostatic nerve block is then performed by injecting 10 milliliters of 1% lignocaine into Denonvillus fascia at the base of the prostate gland bilaterally in equal amounts of 5 milliliter per site, usually using a 22 gauge long Shiba needle. So it's very important as the procedure is to target the neurovascular bundle by administering the anesthetic into the echogenic triangle of fat at the junction of the seminal vesicle and posterior margin of the prostate gland on the axial ultrasound images. And care must be taken to avoid accidental introduction of air, which may obscure the prostate gland. So here you can see transrectal ultrasound probe, which contains the magnetic field receiver being inserted into the patient, and then administration of local anesthesia. And on the ultrasound images, you can see that this shows the axial image appearance of the prostatic base. On the left, we have it before the administration of the periprostatic lignocaine. And on the right, where you can see the area of hypo to end echogenicity at the area of Denonvillus fascia is where lignocaine has been injected. In the third step, truss acquisition and segmentation is performed. The transducer is actually used to perform a craniocaudal sweep of the gland, and the prostate gland is then segmented manually. So what do I mean by that? You can now see the prostate gland being outlined in red, segmented manually on the axial, as well as the truss, sagittal truss images. The fourth step is actually the most important step, in which the system fuses the MRI as well as the truss volumes and presumptively identifies the location of the target lesion on the ultrasound images. So software-based fusion can be rigid or non-rigid, as mentioned earlier, to compensate for the differences in orientation and position of the prostate gland between truss and MR acquisitions, while rigid fusion compensates only for the rotational and translational differences in the orientation of the gland. The technically superior non-rigid or elastic fusion method also compensates for geometrical differences in the gland between the MRI and truss volumes. And once fusion is complete, the biopsy can then be performed. So final step here, fifth step, we have the real-time probe navigation and biopsy. Real-time sampling is performed with the aid of probe tracking technology that allows for real-time navigation. A 26 centimeter long 18 gauge automatic spring-loaded biopsy gun is used to obtain the tissue cores. So currently the recommendations are that we get 2 spatially distributed samples from the particular target lesion in addition to 12 systematic core samples. So I'll just quickly run through one case example. I think Bunta shared quite a few earlier, but let me show you how it's done with regards to intervention. So you can see over here I have 4 images, multiparametric MR done on a 3 Tesla machine. On the top left-hand corner, you can see a T2-weighted hypointense lesion showing early arterial in the left peripheral zone. And on the top right-hand corner, you can see that this lesion shows corresponding early arterial enhancement, as well as in the bottom 2 images demonstrating high DWI signal on the left and low ADC signal on the right. So there is moderate to marked restricted diffusion, and given the size of this lesion, it's a Pirates 5 lesion. So MR localization of the lesion is performed on a T2-weighted axial image seen in the bottom left-hand corner. And then you can corroborate it with the coronal images on the top left-hand, as well as the sagittal image on the top right-hand corner. The segmentation of the lesion is then performed. You can now see that the lesion is outlined. The area of interest is now outlined by this red border. And then the fusion technique is then applied, in which this is actually the most important step in the entire process, in which the volumetric ultrasound image of the prostate gland is now corroborated and fused with the truss image. Fused with the MR image, yeah. The lesion is then localized and segmented, and the suspicious area is outlined on the MRI on the left, overlaid by the 3D truss image on the right. And finally, we show that this prior to injection of the biopsy needle, you can see that without the fusion, the lesion actually looks iso to hypoechoic on the ultrasound image on the left, rendering a bit difficult to detect. So the needle is then introduced in the final step. You can see it being this linear echogenic line coming in posteriorly, and target sampling actually takes place. So there can be some potential complications of fusion biopsy. It is actually similar to that of the standard systematic biopsy, which includes transient hematuria and hematochezia. These commonly occur for a few days following the biopsy, usually managed conservatively and only requires reassurance. Most cases of rectal bleed resolve within 48 hours, and compression with the probe or balloon immediately after the procedure often helps in arresting the bleed. There is also a risk of infection due to the inherent contaminated nature of the transrectal route, although this can be prevented with the use of prophylactic antibiotics. Acute urinary retention and worsening of the lower urinary tract symptoms may also occur due to procedure-related gland edema and can be managed with temporary catheter placement. So in very, very rare cases, there have been reports of erectile dysfunction and vasovagal syncope. Exact mechanism of erectile dysfunction is unknown, but it's been found to be associated with a reduced international index of erectile function at present. Comparing the performance metric of the cognitive and fusion methods, so very briefly, just to reiterate, the cognitive method does not require sophisticated fusion equipment or software, and is comparatively inexpensive. So the AUA SAR actually justifies its use in resource-limited settings. But then again, where expertise and facilities and resources are available, the fusion technique is still recommended. So overall, the cognitive method actually shows a greater amount of interoperator variability due to the reliance on spatial orientation of the lesion from the MR, which is used to direct the ultrasound and biopsy needle by the operator. And comparatively, there's less interoperator variability in the fusion technique, especially when you use the mechanical arm, has led to an increased detection rate of clinically significant prostate cancer. However, from each step of the process still has its own risk of error. So starting from the multiparametric MR acquisition to interpretation to reporting to segmentation, the fusion method and biopsy approach itself has its own risk of error. So for example, the MRs may be misinterpreted, or sometimes there can be inter-reader variability. Targeted biopsies may also miss suspicious lesions due to targeting errors, and unnecessary targeted biopsies may be performed if there were to be false positive multiparametric MR readings. Furthermore, because of possible prostate deformation and movement during the procedure itself, it may be difficult to confirm real-time accurate biopsy deployment within the target, and sampling errors may result. These sampling errors can actually be reduced by spacing out the biopsies and obtaining more targeted cores per lesion, also otherwise known as the focal lesion saturation technique. So in future, the use of multiparametric MR and targeted biopsy can alter the diagnostic pathway of clinically significant prostate cancer. And moving forward, the fusion platforms will continue to evolve. Future developments include automatic segmentation and deformable co-registration with real-time motion correction, combined with improvements in the biopsy procedure. For example, improved ultrasound resolution to further improve targeting accuracy. And there can also be inclusion of use of additional ultrasound techniques such as that of contrast enhanced ultrasound or elastography to refine the fusion techniques in future. Market forces may also help to reduce cost of equipment in future, and hopefully the fusion technique can be made more readily available internationally. The use of multiparametric MR is important as a triage tool before targeted biopsy to improve risk stratification and benefit clinical practice. This can help to improve the quality of care by reducing overdiagnosis and overtreatment. So just some take-home messages to conclude. The fusion technique is fast becoming the standard of care in diagnosing prostate cancer. And given the changing face of prostate cancer screening and cost effectiveness of fusion biopsies with a relatively high diagnostic rate of clinically significant cancer, this technique is likely to exponentially grow in popularity in future. Systematic and targeted fusion biopsy techniques can each identify clinically significant prostate cancer, but the best is that they are used in conjunction with one another, which has shown to provide the greatest sensitivity for detection. So as such, as radiologists, a thorough knowledge of the principles of biopsy techniques is essential to obtain maximum diagnostic yield and to help us in performing these procedures safely. Yeah, thank you very much for your time. I'll hand over back to Kashif.
Thank you, Dr. Nicole. That was a very detailed presentation on MRI truss fusion biopsies. I guess as it becomes more and more common, you will be more and more experienced and give us more information. Thank you so much for your precious time. I think, okay, no doubt, then we will move forward and we will go on to our box of chocolate topic, which is Out of Nowhere, MRI Knee by Dr. Aosor. So it's a great pleasure to introduce Dr. Aosor, who is a very humble person. And Dr. Akhmedov Aosor is from Uzbekistan, National Medical Center, Tashkent. He completed his bachelor's in 2020 and his residency in radiology from Tashkent Medical Academy in 2022. Presently,
for MRI of knee anatomy, and just let's start. MRI of knee anatomy is the most frequently requested MRI joint and in musculoskeletal radiology. The reason is simple, because it works and it gives surgeons information that could not otherwise obtain clinically or non-invasively, and its sensitivity and specificity is high. So let's start with bony structures. Knee joint is composed of 4 bones. It's a femoral bone, tibial bone, and the fibular bone. It's not actually invest in the joint formation, and the patellar bone. And when we are assessing bone structure, we should pay attention bone marrow signal or cortex, and we should pay attention to the cortical structures and congenital development variants like bipartita patella that should not confuse with fractures and dorsal defect of the patella, like in this case, is a well-defined and delineated defect, well-delineated defect as the articular side of the patella, just with a normal cartilage. And the second one is normal development of the irregular ossification of the lateral femoral condyle, just easily can be confused with the osteochondral dissecans. In that we can have here in normal development the normal of cartilage and no bone marrow edema. The bone marrow reconversion is a normal variant of this bone marrow changes. We should differentiate it with leukemic changes. So let's go through the meniscus. Meniscus is a wedge-shaped, crescent-shaped wedge of fibrical thread structures that located on the tibial surface. It has the medial meniscus and the lateral meniscus, and each meniscus composed of the anterior horn, body, and the posterior horn. Anterior horn and posterior horn attached to the central part of the tibia by the roots, and the vascularization of the meniscus is so important because we have three zones. First is the red zone, second is the red-white zone, and third is the inner edge is the white zone. Why should know this for purpose? When tear is located in the red zone, it may heal simultaneously, but tears in third zone, they does not heal by itself, and they may require surgery. A sagittal slice through the body segment of the meniscus represents the classically bow tie appearance, independing on how peripheral is sagittal slice. The medial and lateral meniscus have 2 or 3 sagittal contiguous slices on the body image if the 4 millimeter images are obtained, and the 3 or 4 sagittal images should be through the horns. The posterior horn of the medial meniscus is always bigger than anterior horn. The lateral meniscus, anterior horn of lateral meniscus and posterior horn may be in the same size, but either they may be the posterior horn of either meniscus should never be smaller than anterior horn. In scrollable images, we can see here at the body level. Here you can see the posterior body of the meniscus and the lateral meniscus. Sorry. Here you can see the posterior horn of the meniscus and the anterior horn of the meniscus, and the classically bow tie appearance of the body of the meniscus. So congenital development variants of the meniscus is rare, but you should know this. First one is a hypoplastic meniscus, and second one is anomalous insertion of the medial meniscus, where the anterior horn of the medial meniscus insert just anterior cruciate ligament. The lateral discoid meniscus we have 4 types of discoid meniscus. First is full discoid meniscus. Second one is a partial medial meniscus. Third one is the whisper type. Note that there is no attachment to the posterior tibial. It's just fixed to the whisper ligament. And the last one is very rare. It's called ring type of lateral meniscus. It's just not confused with the bucket handle tears. We can here see the normal of the meniscus without donor side of tear. Myxoid degeneration of the tear. If the high signal disrupts the articular surface, is a torn meniscus. If the high signal does not disrupt the articular surface, it's called just myxoid degeneration. We use two-touch slice rule. It means that we can see this tear on two slices, or it may be on coronal and the sagittal slices to increase our predictability. Here we can see the peripheral meniscal tears. It's called all RAM type tears. You can see here the posterior part of the meniscus, vertical tear of the posterior horn of the meniscus. And second one is meniscocapsular separation, just torn of the meniscocapsular ligament is called of the RAM type 1. And we should differentiate each other is the peripheral meniscal tears is much serious problem for physicians. And do not confuse the vacuum phenomenon, which is intra-articular gas, with meniscal tears. It should be a pitfall for us. And the ligaments, let's start with the anterior cruciate ligament. Anterior cruciate ligament is intra-articular but extrasynovial ligament. It has two bundles, anterior medial and posterior lateral. In axial images, we can see these two bundles. Here is the medial bundle and the anterolateral bundle. And anterior cruciate ligament passes through the medial aspects of intercondylar tibial plateau and passes backward to the upward and backward to the posterior medial aspect of the lateral femoral aspect. In the axial slices, we can see here that it starts here that attaches to the posterior medial aspect of lateral femoral condyle and go through the anterior aspect of intercondylar area of tibial plateau. So next one is posterior cruciate ligament. Posterior cruciate ligament also intra-articular but extrasynovial. These two ligaments is the most stabilizer for knee joint. And posterior cruciate ligament arises of lateral surface of the medial femoral condyle and goes to inferior and the posterior lateral intercondylar surface of tibial plateau. It also consists two bundles, but in MRI images, on MRI images, we can not differentiate these two kinds of bundles. And the next ligament is the medial and lateral retinaculums. We have two retinaculums. Is the most important stabilizer for the patella, and they originate from the lowest fibers of mastus medialis, sartorius, and medullocolateral ligament. The deep layer has contributions from the mediapatellar ligament, and at the lateral retinaculum, the superficial layer organized from the lowest fibers of iliotibial band, and deep layer comprised by lateral patellofemoral ligament. They are well defined and low signal bands, but often difficult to distinguish from superficial and deep layers. The next ligament is medial collateral ligament. It also has two layers. It's a superficial layer that attaches to the posterior part of the femoral epicondyle and the proximal part of medial aspect of the proximal tibia. And we have the deep portions, or we have two deep portions. First is menisca femoral, and second one is menisca tibial. as we see that medial collateral ligament tightly attached to the capsule and the meniscus, it's less mobile and is more susceptible to the injury than lateral collateral ligament. And we should differentiate between the first grade injury of the medial collateral ligament and the medial collateral ligament bursitis, in which we can see here in outer portion of the superficial bands of ligament soft tissue edema. In contrast of medial collateral ligament bursitis, we have a bilobulated fluid that originated between the superficial and deep layers of medial collateral ligament. And the lateral collateral ligament or posterior lateral corner, actually there are 7 or 8 ligaments, but the 3 of them most important. The first is the lateral collateral ligament, which originates from the lateral epicondyle and attaches to the biceps tendon, or by itself it may attach to the fibular head. Second one is the biceps tendon, which attaches to the fibular head. And the last one is the popliteal tendon, which originates from this notch and goes backward to the popliteal muscle. Why is 3 of them important? Because 3 of them surgeons may fix them, because lateral collateral ligament injury or posterior lateral corner ligament injury are often associated with anterior cruciate ligament. If we repair only anterior cruciate ligament and do not repair these structures, it may lead to the non-stabilize of knee joint. The second is the iliotibial band. Iliotibial band originates from iliac crest. It goes down on the lateral surface of the thigh till the anterior portion of the tibial lateral epicondyle. It associated with the iliotibial friction syndrome, where the friction between this bony structure and the iliotibial band, and here can occur chronic inflammation of fatty tissue. The next ligament is the oblique meniscal ligament. It starts with the posterior horn of one meniscus and goes through the central portion of the tibia and attaches to the anterior horn of the next another meniscus. And attachment of the anterior is called by the name. If it attaches to the medial meniscus, anterior of medial meniscus, it's called medial oblique meniscal ligament. And we do not confuse it with a small piece of the tear of meniscus. The next one is the transverse intermeniscal ligament, which attaches between the anterior horn of lateral meniscus and the medial meniscus. And there are also pitfall that we not confuse. Here is like vertical tear in anterior horn of the meniscus. We have 2 meniscofemoral ligaments. It's anterior or posterior, or Risberg and Humphrey. Here you can see the Risberg ligament or posterior meniscofemoral ligament. It attaches to the posterior horn of the lateral meniscus and the lateral aspects of the femoral, medial femoral condyle. And it goes through the posterior part of the posterior cruciate ligament. And here is the thing that Risberg ligament can attaches to the posterior horn of the lateral meniscus, or we can differentiate it with the Risberg rib or the zip tears. are the longitudinal vertical meniscal tears. They occur at the junction of the vertebrate ligament attaches to the posterior horn of the ligament. And due to variability, the ligament attachment site, cleft can extend the variably far and result discrimination between the tear and the perceived tear. It has been postulated that by some authors that attachment site is measured by the lateral aspect of the posterior cruciate ligament till the attachment of the vertebrate ligament. If it's more than 40 millimeters, we suspicious for a tear. And the next one is the anterior meniscofemoral ligament. It also attaches to the posterior horn of the lateral meniscus and the lateral aspects of the femoral condyle, but it goes through the anterior part of the posterior cruciate ligament. The next is the quadriceps tendons and the patellar tendons. Quadriceps tendons originate from the quadriceps muscles and go through the superior portion of the patella and continues to the patellar tendon. They are main extensor tendons, and the patellar tendon also attached to the central of the tibial tuberosity. And we have fat pads. It's 3 fat pads in the anterior part is the prefemoral fat pads and the suprapatellar fat pads and the infrapatellar fat pads, also called the Hoffa fat pad. They may be dropped between the bony structures. It's called the impingement and may cause the pain. And also we have a fat pad in the posterior aspects of the joint. It's called the posterior fat pad. Like other some joints, knee joint is also synovial joint. It means that it has a thick fibrous capsule and the synovial joint, which means a synovial joint, synovium, inner part of the synovium, they secrete the synovial fluid, which is lubricates the knee joint. In addition, in the knee joint, we have bursa and recesses. Bursa are the sacs surrounding the knee joint that fill it with synovial fluid. They facilitate movement between the muscles and the bony structures. They may communicate with the articular joint space or non-communicate. We can divide all recess and bursa in 4 compartments. It's anterior compartment, posterior, and lateral and medial compartment. Let's start with the anterior compartment. First is suprapatellar bursa. It's located between the patella and quadriceps tendon and the femoral bone. Second one is the prepatellar bursa that is often seen in the housemaid knee. It's called housemaid knee, and they're located between the patella and the skin, superficial skin. Deep infrapatellar bursa is located between the distal portion of the patellar tendon and the anterior part of the tibia. And we have 2 recesses. It's a supraophic recesses, just inferior part in the inferior part of the patella, and the infraophic recess is just inferior and anterior part of this Hoffa pad. Also, we have central synovial recess. It's just anterior to the anterior cruciate ligament. And we have a posterior bursa and recesses is one of the main bursa. It's called gastrocnemius and semimembranosus bursa. It's also called Baker cyst, which originated between the medial gastrocnemius and semimembranous tendon. And the next one is subpopliteus bursa. It's located between the popliteus tendon and the posterior horn of the lateral meniscus. And we have recesses, medial and lateral posterior femoral recesses or gastrocnemius bursa between the articular and in each part of the back in the posterior aspect of the femoral. And we have a posterior capsular recess is the outpouching of the synovium in the just behind the posterior cruciate ligament. In lateral compartment, we have lateral collateral ligament and biceps bursa. That's named is located between the lateral collateral ligament and the biceps femoris bursa. And the second that I mentioned earlier is the iliotibial bursa, located between the iliotibial band and the femoral epicondyle, lateral femoral epicondyle. Also, we have a parameniscal recesses is the superior and the inferior parameniscal recesses. It's associated between the flap tears when the piece of meniscus can go migrate into this parameniscal recesses. And the last one is the medial compartment, is the medial collateral bursa, just located between the superficial and the deep layers of the medial collateral ligament, and the pes arcerinus bursa is located between the tendons of this pes arcerinus tendon. And the last one is the medial collateral ligament and semimembranous bursa is located just lateral part of the semimembranous bursa and medial collateral ligament, just not to confuse is with the Baker cyst. Thank you for your attention.
Thank you, Dr. Elior. It was a nice recap and a very nice, I would say, a pictorial representation of anatomy and pathology of MRI of knee joint. I am sure that this was a delight for junior residents. So with that ado, I think now we are coming to the end of all the sessions. I am grateful to all the speakers who provided their valuable time. And please scan the QR code for getting the certificate. There is a small feedback form attached. Kindly fill it. It will take less than a minute. I am thankful to all the speakers who gave the time. I'm thankful to AOSR, AOSOR for giving me the opportunity, especially the AOSOR Youth Club. And special mention